This lecture will be going over Chapter 5, Care of Postoperative Surgical Patients in the Med-Surg textbook. When surgery with general anesthesia is completed, the patient is usually transferred to the Post-Anesthesia Care Unit, or PACU, that is typically adjacent to surgical suites. Very critically ill patients, such as those recovering from open heart surgery, are often taken directly to the ICU for anesthesia recovery. The PACU nurse will receive a verbal report from the anesthesia care provider about the procedure, any blood loss, anesthesia administered, any fluids infused, medications administered, and any problems encountered. The patient is immediately attached to the cardiac and pulse oximeter monitors, and oxygen is usually administered if the patient had general anesthesia. Oxygen will help eliminate the anesthetic gases and will also help meet the increased metabolic demand for oxygen caused by the surgery. An oral airway, laryngeal mask airway, or endotracheal tube may still be in place because the anesthesia medications will often relax the tongue enough to occlude the airway, and the patient may not be awake enough for removal of that airway device. Suction should be turned on and readily available to clear any secretions. Warm blankets are placed over the patient, vital signs are assessed and compared with baseline readings, and a full neurologic assessment needs to be performed. Neurologic assessment will include your level of consciousness, orientation, sensory and motor status, as well as the size, equality, and reactivity of pupils. The patient might be asleep, drowsy, but arousable or awake. Check all IV lines for patency and verify that the solutions and flow rate are correct. Inspect any wound drains and evacuation devices for proper function. Assess any dressings for unexpected drainage. Surgical recovery can take from 1 to 6 hours. The time of stay in the PACU will be determined by the operative procedure as well as the type of anesthesia that was used. Assess for return of the gag reflex by determining whether or not the patient can swallow their own secretions. The patient might wake up confused and might need reorientation as well as reassurance that the surgery is over, that they're in the recovery room, and that their family member or contact person has been notified. Assessment should be done every 15 minutes or according to the status of the patient. The patient will remain in the PACU until vital signs are stable and the patient is awake and able to respond to stimuli. A form of the Aldrete scoring system or other system should be used to determine the readiness for transfer. Activity, respiration, circulation, consciousness, skin color, and oxygen saturation are all given a score. The patient with a score of a 9 or 10 is ready for transfer to the nursing unit. For many procedures, the patient may be transferred from the operating room directly back to the same-day surgery unit. When the vital signs are stable, the patient should be allowed to sit up and then ambulate. If discharge criteria have been met, the patient can be discharged when able to ambulate without assistance, can take fluids without nausea, as well as empty their bladder. Advise surgery patients who haven't received anesthesia or Advise surgery patients who have received anesthesia or procedural sedation not to resume normal activities and not to make any important decisions for at least 24 hours after their surgery. After the patient is transferred from recovery, check their identity, settle them in bed, and perform an initial post-operative assessment. Airway, breathing, and circulation are always our top priorities. Vital signs need to be taken more frequently if they're unstable. This is based upon your nursing judgment. The first 72 hours after surgery will require frequent observations to detect any post-operative complications. When planning your work for the shift, you must allow time for frequent post-operative assessments. Post-operative patients are at risk for respiratory problems from the effects of anesthesia on the lungs, being in one position for the duration of the surgery, as well as limited mobility in the immediate post-operative period. Maintaining a patient airway is a priority measure to promote oxygenation and ventilation. Unless contraindicated, the patient should be positioned on their side with their head turned to the side. This is to prevent aspiration until fully recovered and alert, and the gag reflex is intact. Monitor end tidal CO2 if it is indicated to assess for adequate ventilation. Some degree of atelectasis will exist after anesthesia. A mild hypoxia is typically present for about 48 hours after surgery. If any area of the lung remains atelectic for more than 72 hours, hypostatic pneumonia from retained secretions is likely to occur. A low-grade fever in the first 24 to 48 hours will often indicate atelectasis. Hypostatic pneumonia can result when the lack of movement or position changes causes stasis of secretions, which then become a breeding ground for bacteria. Auscultate the lungs carefully for any abnormal sounds. Assess the rate and depth of breathing and encourage your patient to deep breathe and cough every 2 hours. If the patient cannot cough effectively, instruct the patient to huff cough. If the patient is too weak to remove secretions, tracheal suctioning is indicated. Huff coughing can prevent atelectasis. It should be done every 2 hours. Ensure that the patient turns every 2 hours, which will change the distribution of gas and blood flow in their lungs, as well as help move secretions. Early ambulation will be ordered to promote ventilation. The use of an incentive spirometer is especially helpful to prevent atelectasis and hypoventilation. This should be used every hour while the patient is awake for the first 24 hours after surgery, and then every 2 hours thereafter. Take a look on page 87 at the red box with the older adult care points. The risk of hypoventilation is greater in older adults because their lung expansion might be hampered due to calcification of costal cartilage as well as weakened respiratory muscles. End tidal CO2 monitoring is effective in identifying hypoventilation in at-risk patients. A pulse oximeter should also be used to determine blood oxygenation. Monitor their oxygen readings periodically and report any oxygen saturation readings below 95%. When considerable blood is lost during surgery, a blood transfusion may be ordered. Autologous blood may be transfused if the patient donated blood several weeks before surgery, or if the patient's blood was collected as it was lost during the surgery. If surgery involves an extremity, or if a procedure has been performed on any major blood vessel, the distal or peripheral pulse must be checked during each full assessment. The skin distal to the surgical site should be warm to the touch, and there should be brisk capillary refill in all the fingers or toes. Color, movement, and sensation of the fingers and toes should be checked to detect any nerve or blood vessel compression due to swelling or edema. Blood pressure and pulse need to be compared with preoperative values to determine whether or not there are any significant changes. An increase in the pulse could indicate that internal bleeding is occurring, but it could also signify incomplete pain control. Blood pressure that falls below the patient's normal baseline level could indicate major bleeding. The use of sequential compression devices, or SCDs, on the legs is recommended. The SCDs need to be checked frequently to ensure that they properly fit and function. They should be removed at least once per shift to allow for air circulation on the skin, as well as for bathing and a full skin inspection. As danger of thrombosis decreases, compression stockings could take the place of SCDs. These stockings need to be fitted correctly, and they need to be checked frequently to ensure that their fit is smooth. Low molecular weight subcutaneous heparin injections can also be ordered as a general precaution, as well as for any patient with a history of thrombophlebitis or is at a higher risk for thrombosis. Question the patient about any pain, swelling, or tenderness in their legs. If the patient complains of leg pain, you must gently assess the skin for any increased warmth and then notify your surgeon. Safety is a primary concern until the patient is fully recovered from anesthesia. Always leave the bed in the low position after administering care. Remind the patient to call for assistance as needed and be certain that their call light is within reach. Remember that you are your patient's advocate while they're recovering for surgery and anesthesia or under the influence of a narcotic analgesia. Reassure these patients who have had spinal anesthesia that it's normal for their legs to feel numb and heavy and that the feeling will soon return to normal. A feeling of pins and needles in the legs is also common. Lying flat for 6 to 8 hours can decrease the chance of a post-spinal anesthesia headache. If a headache does develop, staying flat in the bed will reduce the pain. Keep IV fluid running as ordered. Encourage your patient to increase their fluid intake, including any fluids containing caffeine. Check pressure points related to the position that the patient was in during surgery, and provide any padding and appropriate positioning for areas that are painful. Good hand hygiene is the primary means of preventing infection. Encourage fluid intake to flush the bladder, therefore preventing a bladder infection in patients who are catheterized or have an indwelling catheter. Core measures state that if a patient is receiving a prophylactic antibiotic, it needs to be discontinued within 24 hours after surgery. Keeping blood glucose within normal limits will also help prevent a wound infection. Urine output is closely monitored after surgery. Report a urine flow of less than 30 mL per hour to your charge nurse or surgeon. A patient without a catheter in place must void within 4 to 8 hours, depending on the type of surgery and anesthesia used. If the patient is unable to empty their bladder spontaneously, you must obtain a bladder scan and, if needed, an order for a catheterization. If the flow is less than 60 mL over a 2-hour period, the surgeon needs to be notified. Patients will usually return from surgery with an IV infusion running. Be sure to check your orders to make sure it's the correct order. No potassium additive should be given until the urine flow is at least 30 mL per hour. Assess the IV site every hour for patency, flow rate, and complications. As soon as the patient is conscious and the gag reflex has returned, offer them a few ice chips or sips of water, unless there's an order to maintain their NPO status. Postoperatively, the output should slowly increase until it is more than their intake, and after about 2 to 3 days, fluid should again be balanced. Anesthesia can cause nausea and vomiting. Keep the emesis basin or bag close by and position your patient on their side to prevent any aspiration. To prevent stress on the incision and sutures, it's best to medicate the patient before any actual vomiting occurs. Apply a cool cloth to the forehead and the back of the neck. Rinse the mouth, rid the room of odors, and provide a quiet environment to help reduce nausea. After emesis, mouth care needs to be provided. If vomiting is uncontrolled with medication, an NG tube that suctions the stomach contents may need to be inserted. When an NG tube is in place, be sure to check its positioning and functioning correctly, as well as the suction being set according to orders. Assess the amount of drainage produced every 1 to 2 hours, and report the presence of blood to the surgeon. A patient who is NPO and kept on IV fluids will lose some weight because there are insufficient calories in the IV fluids to meet their total daily requirements. A liter of 5% dextrose in water contains only 200 calories. After surgery that required general anesthesia, the patient will not be allowed to eat solid foods until their bowel sounds have returned. This is due to the risk of developing a paralytic ileus. This is the failure of forward movement of the bowel contents. At least once per shift, or according to your hospital policy, you must listen for bowel sounds in all 4 quadrants. Discomfort from abdominal distension and considerable flatulence may occur after general anesthesia. This is due to the decreased or absent peristaltis. Taking only small amounts of liquid or food at a time, drinking tepid liquids, and refraining from drinking with a straw can help keep flatulence to a minimum. Ambulating will also help move and evacuate the gas. Once a patient is eating again, a bowel movement should occur within 2 to 3 days. Patients receiving narcotic analgesics may become constipated and require a stool softener or laxative in order to produce a normal bowel movement. Pain and discomfort can interfere with rest, as well as inhibit the processes of healing and repair. Opioids tend to depress respirations and the cough reflex. Therefore, they may contribute to the development of pulmonary problems. They can also increase the possibility of nausea and vomiting. Pain must be reduced so that the patient can rest, turn, cough, deep breathe frequently, and ambulate as soon as possible. Medications need to be given consistently for the first 24 to 48 hours postoperatively. Be sure to assess the pain level and effectiveness of analgesia using a pain scale, and do this every 2 to 3 hours. If it is too soon to give more analgesia medication, reposition the patient. Be sure that their bladder is not distended and causing any discomfort. Check that the patient is warm enough and use other comfort measures, such as distraction or imagery, to relieve their pain. Note when the analgesia medication is due again and have it ready to administer at that appointed time. Teach relaxation techniques that can help decrease a patient's discomfort. 3 methods commonly used for pain control are the PCA pump, the epidural catheter, and the continuous peripheral nerve block for extremity pain. A patient's temperature in this environment will often decrease, especially during prolonged abdominal surgery in which the peritoneal cavity has been open for a long period of time. Postoperatively, the patient could feel cold and they need to be kept warm with extra blankets or warmed bath blankets applied under the top covers. Some anesthetic agents can also cause tremors as they're metabolized. This will typically occur in the PACU phase of care. If uncontrollable shivering occurs, contact your surgeon for medication orders. Dressings on the extremities need to be checked to be certain that they are not too tight to impair circulation. You should be able to slip your little finger between a dressing and the extremity. Occasionally, continuous hiccups will occur after surgery, making a patient quite uncomfortable. Having the patient breathe into a paper bag can often relieve these hiccups, and sedatives and tranquilizers may need to be prescribed to promote relaxation as well as reduce irritation of the phrenic nerve. Patients need sleep after surgery. Keep the room quiet and group any nursing activities to prevent waking the patient more often than is necessary. Orders for ambulation might begin within several hours after surgery. Raise the head of the bed first and let the body adjust to the position change. Then sit them on the side of the bed, allowing their legs to dangle over the side of the bed with the feet on the floor or on a footstool. After a few minutes, slowly assist the patient to stand. Assist the patient to walk around the room or at least take a few steps. Emphasize that exercise is vital to preventing circulatory problems and offer praise for all efforts. Continue to ambulate in the hospital or at home on a set schedule until the patient can do so independently. If the patient is on strict bed rest, range of motion exercises need to be performed at least 4 times per day. Surgical incisions most often heal by primary or first intention. Adequate rest, sufficient blood supply, and proper nutrition will all promote wound healing. Proteins can provide amino acids that are the building blocks of tissue, and they are vital to our healing process. Good circulation will ensure that blood reaches the wound. Mechanical injury from friction, pressure, or abrasion, such can occur when tape is removed, will disrupt the healing tissue and prolong wound healing. Be sure to handle all wounds gently and shield them from any injury. When dressings are removed from a wound, take care not to dislodge any granulation tissue. Smoking will decrease the amount of hemoglobin available to carry oxygen to the healing tissues and will prolong healing time. Corticosteroids taken for a chronic condition will also slow the healing process because they suppress the immune and inflammatory responses. Excessive stress, apprehension, and emotional disturbances seem to make the body more vulnerable to invasion by foreign organisms by depressing the immune system. The surgical wound should be inspected during dressing changes, or at least once a day. Normally, a surgical wound is sealed within hours, and little drainage is expected. The surgical incision is usually kept covered with a dressing in place in the OR for a minimum of 2 hours. Document the appearance of any drainage. Drainage can be serous, which is clear or a very light yellow, serosanguinous, which is a reddish yellow, or sanguinous, which is blood, red. The best way to prevent hospital-acquired infections of a surgical wound is to always wash your hands before doing wound care or touching the patient, to use aseptic technique as well as standard precautions for dressing changes, and to change dressings as ordered. The wound needs to be properly splinted for any coughing to prevent dehiscence of the incision. Surgical dressing should be checked each time vital signs are taken for the first 24 hours after surgery, then every 4 hours for the next 24 hours, and then every 8 hours for as long as the surgical wound is kept covered with a dressing. If a wound is not expected to drain, but drainage is evident, the surgeon needs to be notified. The surgeon will typically perform the first dressing change. When there is excessive drainage, the dressing will probably require reinforcing every 4 hours. Changing the dressing more often than once a shift is not recommended due to the dangers of introducing infectious agents, of traumatizing the wound, and of interfering with tissue regeneration. Each time a dressing is changed as ordered, the amount and characteristics of drainage on the dressing need to be noted and documented. An infected wound should be cultured to see what organism is causing that infection. Drains are used to prevent accumulation of fluids or air at the operative site, also to protect suture lines and to remove specific fluids, such as bile, cerebrospinal fluid, or drainage from an abscess. If a drain is kinked, the accumulated fluid and gas can cause pain, create dead air space, which can delay healing, damage the healing tissue at the suture lines, and delay healing by compressing surrounding capillaries and cutting off oxygen supply to the cells. Negative pressure drainage systems consist of a semi-occlusive dressing that has tubing connected to a vacuum device. This technique can also be called vacuum-assisted wound closure. The negative pressure dressing and system promote wound healing through direct and indirect effects. On page 93, we can see some different wound drains. When an order is written to remove sutures or staples, check your order, gather your proper equipment, and inform your patient about the procedure. Correctly identify your patient, wash hands, don gloves, and inspect your incision carefully. For a long incision or incision over a joint, remove every other suture or staple first. Wound infection. A prophylactic antibiotic after surgery can be ordered to help prevent a wound infection. If an infection is going to develop, it usually will become apparent 2 to 7 days postoperatively. Most patients will already be at home when postoperative infection becomes evident. If an infection occurs, culture needs to be obtained, and appropriate antibiotics should be given for a specific length of time. A non-infected wound should be cleaned or irrigated with anything but sterile normal saline. A non-infected wound should not be cleaned or irrigated with anything but sterile normal saline. Any other substances will irritate the tissue as well as slow healing. Soiled dressings and supplies need to be bagged in a plastic barrier bag and deposited in a biohazard trash receptacle. Dressings from an infected wound should never be placed in the patient's room trash container. When caring for a patient who has undergone an abdominal surgery, you must be alert for the possible disruption or separation of some or all layers of their surgical wound. This is called dehiscence. If the wound completely separates and the contents of the abdominal cavity protrude through the incision, that is called evisceration. Patients at most risk for dehiscence and evisceration are those who are diabetic, obese, malnourished, or dehydrated, have a malignancy, have experienced multiple traumas to the abdomen, or have an infected wound. Wound dehiscence may be partial or complete. Most wound dehiscence is secondary to infection, so treatment will commonly include antibiotics. A wound anywhere on the body can dehiss, but evisceration can occur only in abdominal wounds. Evisceration creates an emergency that requires immediate surgery and is a very serious complication. The most common complication of anesthesia medications is respiratory depression, compounded by administration of opioid pain medications. In addition to the respiratory assessment, vital signs will indicate if hypotension is present. Shock, which can quickly develop into a life-threatening emergency, will present the most immediate danger to the patient. Shock disrupts normal physiologic function and can result from failure of the heart to function as a pump, known as cardiogenic shock, seen in cardiac arrest. It can be caused due to a low volume of blood, known as hypovolemic shock, such as in a hemorrhage, or dilation of the blood vessels as due to faulty nervous system regulation, or distributive shock. This would include anaphylaxis, like hypersensitivity to a drug or another allergen. Shock can also result from sepsis, which occurs when toxins from bacteria relax and dilate blood vessels, resulting from a drop in blood pressure. As shock progresses, BP begins to drop and your pulse rate increases. Skin becomes cold and clammy, and pallor becomes evident. As shock deepens, blood pressure will continue to fall, the patient will lose consciousness, eventually becoming comatose. Untreated shock is fatal. Both general and local anesthesia can bring about some type of circulatory collapse. Malignant hyperthermia is a rare but life-threatening complication of general anesthetic agents. This includes halothane, isoflurane, enflurane, and succinylcholine. MH occurs from a biochemical reaction in genetically predisposed persons. Most MH occurs during the surgical procedure in the OR. Signs of MH include high temperature, cardiac dysrhythmia, rigidity of the jaw or other muscles, hypotension, tachypnea, and dark cola-colored urine. A late sign of MH is an extremely high temperature, up to 111.2 degrees Fahrenheit. Dantrolene is the drug of choice to treat this condition. When surgery alters physical appearance, the patient may not only be concerned about the ability to perform their self-care postoperatively, but they may also have considerable changes in their body image, particularly if there's any extensive scarring. Assess your patient for any signs of ineffective coping, including withdrawn, depressed behavior, less attention to grooming than before, and poor communication efforts. Help the patient by encouraging discussion of feelings regarding what has been removed and the effect that it might have on the patient's life. It can help to refer the patient to a support group of people who have undergone a similar experience and are also learning to cope. With same-day surgery and early release from the hospital after inpatient surgery, it is vital that discharge planning be started at admission or several days before the surgery. Be sure to assess the need for any home care. Equipment such as oxygen, suction, or an IV pump may need to be ordered before discharge so that the transition to go home goes smoothly. Family or relatives should be included in the discharge planning and teaching. When the patient is discharged, review specific instructions regarding care at home, including care of the incision or wound, diet requirements, activity level allowed, medications, and signs and symptoms of complications to report to the healthcare provider. The patient may be given a follow-up care at an outpatient clinic, healthcare provider's office, subacute care unit, rehabilitation unit, or extended care unit at the patient's home. You should assess the patient's condition and progress, perform treatments and procedures such as wound care, and reinforce teaching about the signs and symptoms of complications. The quality of nursing care delivered postoperatively is often the factor that will prevent complications and rehospitalization. Even patients who are ambulatory and normally self-sufficient will usually need assistance or reassurance with anything more than a simple dressing change. This is particularly true if the patient lives alone. You must verify that the patient can adequately perform self-care and collaborate with the patient, healthcare provider, social worker, and community agencies to secure the assistance that the patient needs.